Welcome to Surgeon's Log 2020, Case Archives of the Skull Base and Beyond, a webinar presented by the North American Skull Base Society in association with Global Brain Surgery Initiative. I'm your host, Dr. Walter Jean of George Washington University. If you've enjoyed this and other episodes, don't forget to click the subscribe button on our YouTube channel so that you don't miss any future episodes. For now, put on your learning hats and enjoy this episode of Surgeon's Log 2020. It's nighttime here in the U.S., so good evening to all the U.S. Attendees. A little late afternoon in the West Coast. You can see that from Dr. Huang's background there. So welcome everybody. I don't think we're going to get lots of African and European friends today, but maybe they'll see it on YouTube, and our Asian friends might be wide awake today in the morning on Friday. So thank you for joining us on this 10th episode. We have a great panel and a great episode in store for you. And without further ado, Dr. Huang, if you don't share your slides, I'll introduce the panelists. As you all know, I always thank our panelists profusely because they really drive the seminar. Today I have a special thank you for Dr. Ed Vates for joining us because he really jumped in the last minute. We had a presenter that was scheduled for this episode that was going to do a specific case, and the very last minute that presenter had to cancel. And so I went for rescue from my old roommate, and Dr. Vates, sure enough, was able to pull things together and join us last minute. So my profuse thanks for Dr. Vates. Our discussant today will be Professor Juan Fernandez-Miranda from Stanford, who needs no introduction. He is, of course, bossing the Roten Society meeting that we will talk about at the end as we speak these last couple of weeks. So he's all on webinar out these last couple of weeks. Next slide, please, Mike. On the hot seat today, we have Dr. David Paul from the University of Rochester at PGY5. And for the second time in a row, I am not the moderator. I'm very happy about that. And my co-course director of Surgeon's Log 2020, Dr. Michael Huang, will be moderating and quizzing Dr. Paul today. So without further ado, gentlemen, go ahead.
All right, thank you very much. So the case for today, named Taming Goliath. So David, you're seeing a 51-year-old woman who comes to you with complaints of what she calls migraine headaches that have been ongoing for about 2 years. In addition to these headaches, she reports she has some intermittent jaw pain, tingling, and also some hand and arm pain and numbness that are somewhat positional and just overall fatigue. Other things that she has noted is sleep apnea. She's been diagnosed with bilateral carpal tunnel syndrome, so far no surgery. She has infertility, not just related to her age, but has been an issue of her life, and also more recently bilateral knee arthritis. So given these symptoms, David, what are you thinking of right now?
Yeah. So given the things that are on this list in her presentation, I'm concerned that she may have acromegaly based upon sort of the constellation of symptoms that we have here. But there are probably a few other things that I would just want to ask about sort of her personal appearance, whether she's had frontal bossing, she's had a change in shoe size, if she's had any sort of palpitations or cardiac symptoms. And then I'd want to do some laboratory workup to nail the diagnosis.
Got it.
So
Okay, yeah.
on laboratory, go ahead.
Oh no, so you examine her, and she does have a clear stigmata of acromegaly. You mentioned a couple of them, like the frontal bossing. What else would you be looking for on the exam?
Yeah, so in someone who I'm concerned about acromegaly, who also has headaches, in addition to sort of the phenotypic presentation, I'd be concerned about their visual function, wondering whether or not they've had any blurry vision, peripheral vision loss. Those would be the sorts of kinds of questions I would be asking.
Okay, yeah. So other than the physical appearance of acromegaly, she is otherwise neurologically intact with no visual complaints.
Okay.
So you asked for labs, but before we get there, here is her MRI scan.
Okay. Nice.
Oh,
So here we have T1 weighted MRI, a coronal and sagittal at the level of the pituitary with contrast, demonstrating a cellar lesion. That its origin is in the cella. It has some paracellar extension. There appears to be a cystic component along the superior aspect of this lesion. The lesion appears to go into the cavernous sinus on the patient's right. It appears to just stop at the lateral edge of the cavernous sinus. That would probably be a grade 2 lesion, I would believe. It doesn't quite pass the lateral border of the carotid on that end. It looks like it's pushing the diaphragm superiorly, and I would imagine the normal pituitary gland is on the superior left aspect of the lesion, given the fact that the cavernous sinus is vated on the right. I do not clearly, actually I do. There's actually a very small iso-intense rim layered above the superior aspect of the lesion that I would imagine is the optic chiasm. There is some invagination, but not extension into the third ventricle. The cella looks to be expanded. The MRI is not great for bone, but I'd be concerned if whether or not there's any bony erosion on the undersurface of this. So here's a bone windows of the CT, which shows thinning of the bone. There's probably a very small rim of bone that's remaining. It's well pneumatized sinus.
That's an excellent description. Anything else on this sagittal CT that will be important for your surgical planning?
So looking at the ethmoid, go ahead.
Is there anything that should be there that's not there?
So your arrow is pointed towards the clivus, and the dorsum sella is not present. So the sort of the posterior aspect of the cella is missing.
Correct. All right, and then so you already mentioned. So well, to summarize, what is this?
So this is a pituitary adenoma. Given her clinical presentation, we don't have laboratory evaluation back. The differential is most likely acromegaly, but other forms of pituitary adenoma would be less likely on the differential. So the next thing that I would do, again, is we would confirm the diagnosis with the laboratory evaluation. I'd want to get IGF. When the patient has clear clinical symptoms, IGF is sufficient to, I think, nail the diagnosis. If the symptoms are unclear, then you 100% probably need to follow it up with the oral glucose test. And then I would get the rest of the pituitary labs to make sure we're not dealing with something that's plurihormonal or also concern for pan-hypopituitarism.
Okay. And any other studies you will want to obtain?
Oh, yes, most definitely. So given the fact that the optic chiasm is draped over the surface, the patient says that they don't have any visual symptoms, but I'd like to get sort of baseline ophthalmologic assessment It'd be neat if it was available, but here oftentimes we also get optical coherence tomography. So in patients who actually do have poor vision, the retinal nerve fiber layer thickness gives us a number that we can use to counsel patients on the likelihood of their visual recovery. And then I think it's if available, it would be nice to have vascular imaging. You can see the carotids pretty clearly, but it's just nice to be able to map out the extent of the carotid arteries.
Okay, those are all excellent. Anything else in terms from a systemic perspective for patients with
Yeah,
acromegaly?
so, you know, this is a patient who, you know, definitive treatment for acromegaly is surgery. So when you think about working this patient up for surgery, a patient with acromegaly is going to have some risk factors. So, you know, I would partner with my ENT colleagues because these patients are at high risk for sort of macroglossia, you know, subglottic hypertrophy, and difficult airway. So I want to make sure that my ENT colleagues are on top of that, that they know that this is a patient with acromegaly, that they're present in the operating room for intubation in case an alternative airway needs to be established. I'd also want to get an EKG, assess whether or not the patient has anything like hypertrophic cardiomyopathy that would be an anesthetic risk factor.
Great. Here are the results of her laboratory workup. And also she underwent an echocardiogram, which showed it was normal. And acromegalic patients have some increased risk for cancer, especially for colorectal cancer. So she underwent a colonoscopy, but did not find any cancerous lesions. And then from the results, you can see her IGF-1 and her growth hormone levels are also elevated, confirming the diagnosis here. So what are we going to do about this? So what is your goal?
May I interrupt, Dr. Huang? Sorry to interrupt there. David, you mentioned a grade when you looked at the MRI scan. As I often warn trainees when we go sit on the hot seat or actually take the board exam, anytime you mention something, it opens the door for the examiner to really get into it and dig into it. So what grade are you talking about? And careful with pronunciation of that word. And what are the grades? What are the grades?
Yeah, so this is a NOSP grade. It evaluates the amount of cavernous sinus invasion. So it's grade 1 through 4. I guess you could, or 0 through 4. But basically, the lowest grade is no invasion of the cavernous sinus. The first grade, or so the first and second grade, basically is incremental invasion up to the lateral wall of the carotid artery. And then there's a grade 3A, which is invasion of the superior lateral aspect of the cavernous sinus. Grade 3B is invasion of the inferior lateral aspect. And then grade 4 is fully encasing the carotid artery.
So your grade for this one was?
I gave it a grade 2 because it doesn't quite go all the way into the superior lateral aspect of the cavernous sinus.
So yeah, so the grading, you look at the 3 tangential lines, well, medial wall, cross section of the carotid, and then the lateral border. So this one reaches the lateral border, but it's not encasing the carotid, which will be a grade 4. So I think this is actually a 3A grade here.
Juan,
Okay.
would you agree, disagree?
No, I totally agree. It's of course not a grade 2, it's a grade 3, A. And I would like to see the sagittal, I always like to see the sagittal at the level of the carotid loop to see if there is also inferior compartment invasion. It could be a 3A and B. I suspect there could be some inferior compartment. I don't know. I don't have enough information there.
Right, okay.
Okay. So can you talk a little bit about the natural history of acromegaly. So what would happen if we don't do anything, if we leave the growth hormone unopposed?
Yeah. So if you leave the growth hormone unopposed, the patient would just have more gross presentation of the phenotypic sort of findings. Patients are at risk of dying from heart failure, from their cardiomyopathy. I think that's the number one issue. They have significant reduction in their length of life. So the natural history is that they don't resolve on their own. They don't get better on their own. They're insidious lesions. They will continue to grow. So that's why patients often come in with macroadenomas, and they're slow growing. But they would have a loss of several years of their life, and they'd probably have complications of cardiomyopathy.
Yeah. So yes, you're right. So yeah, cardiomyopathy is the most common cause of mortality in these patients, and they usually have about a 2 to 3-fold increase if they're not treated. So what is your goal for treatment in this patient?
Yeah. So goal for treatment here would be gross total resection. It depends. There's a few factors that sort of go into whether or not these patients are very sensitive to medication or not. But we know that if you remove all of the tumor, patients have a positive hormonal response to that. They actually, their sort of life expectancy actually returns back to the normal life expectancy of the general population. So the goal is to get rid of all of the tumor as safely as possible. If that's not possible, obviously there's somatostatin receptor ligand therapy for these patients. But that therapy, sometimes these tumors aren't extremely responsive to the therapy. So the goal is to debulk it as much as possible, gross total resection, and reduce the hormonal burden.
Yeah. And what would you quote the patient? What would you tell her the likelihood of achieving such a surgical cure in this case?
I honestly think it's it would be patient specific. So I don't think that there's a one-all answer for patients, but in this patient's particular case, with the invasion of the cavernous sinus, I would let her know that we would, our goal would be to achieve gross total resection. We would do so in the safest fashion possible. However, we would have a serious conversation about the fact that this tumor is encasing her, her carotid artery. And if for some reason there was an issue where we wouldn't be able to get everything in the cavernous sinus and we had to leave something behind, that we would. So I would counsel her that is a realistic possibility. I don't have a percentage that I can give her. I think that usually is about I believe like 50. I would say 50% with this amount of cavernous sinus involvement. But I don't know that I have a decent amount of literature to back that up, and it would probably be dependent upon my hands as a surgeon with similar cases.
So yeah, so you mentioned, obviously the sinus involvement makes it more likely that there will be some residual, but given that this is a functional tumor, how aggressive are you going to be with the cavernous sinus component?
I mean, I'd be fairly aggressive. For example, if it was a prolactinoma, for instance, prolactinoma is gonna, if the patient for some reason had like apoplexy or some other reason to sort of operate or intervene on those patients, we know that prolactinomas are usually sensitive to gerbergaline. So if you leave something behind, you can treat it with medical therapy. If you leave something behind in this instance, you'll probably need to look at things like radiation therapy, because, you know, like I said, the goal is to be as aggressive as possible in a safe fashion and get rid of all of the tumor. And, you know, we treat any residual with, you know, somatostatin receptor ligand therapy and radiation therapy.
Okay. How does the optic nerve, optic chiasm elevation compression play into your surgical planning?
Well, in this instance, the sort of the dome of the lesion is smooth in appearance. It doesn't seem to have, it seems to be contained, you know, within the dorsum sella. So I think that this patient would be very amenable to an endoscopic intranasal approach. And, you know, that we should be able to safely get all of the intracellular and you know, and the supracellular component of this tumor.
Okay. So going on, so you have mentioned that your approach is going to be endoscopic, intranasal, transphenoidal. So, you know, going through the case a little bit, the operation. So what are some of the complications that you would be concerned about, and what kind of preoperative and intraoperative maneuvers are you going to do to help avoid those complications?
Yeah. So in this instance, you're going to be worried about sort of as you approach mucosal hypertrophy. So you'll want to work with your ENT colleagues to make sure that you have sort of good visualization and that you're able to get down to sphenoid os appropriately. The sphenoid sinus is well pneumatized, so that's great. The one major issue would be the fact that there's bony erosion. So your normal landmarks and the bony prominences may not be as clear. You know, when you come down on the surface of the sella, you're looking for you know, your optical carotid recess, the protuberances associated with the optic nerve and the carotid artery, and those may not be as clear. The other thing is that, you know, and we had discussed this as well, is that once you're, you know, actually doing your resection, you have to be careful that there's not a posterior wall there to the sella, and that you know, that wall is a source of protection, and you need to be conscious that you're not going to be protected there, and that's going to be a risk of causing some damage.
And with regards to the actual tumor resection itself, how are you going to approach that?
Yeah, so you know, once so I would do a lumbar drain, and I do fluorescein. Would obviously just the standard approach with sphenoidotomies. I would identify. I would use Doppler in this instance because my bony landmarks would not be as well visualized. So I'd want to make sure that I identify the carotid on both ends to mark out sort of the lateral extent of my my bony opening. I'd want to be. I would want to have a bony opening as possible, and basically from the clivus to the tuberculum. And I'd open up in a X-shaped fashion. I'd allow the sort of the tumor that's there to kind of deliver itself. I would debulk sort of the inferior and middle portion. I'd be very careful with the fact that you know, I don't have that posterior wall. So I'd probably after debulking the middle portion, I'd probably want to switch to a sort of an extra capsular approach so that I have good visualization of all my structures around. I'd start taking down the wall, the capsule in circumferential fashion, starting from the bottom and then working my way in both sides. I'd start to sort of involute the capsule down and continue to work my way up to the top. And then I would turn my attention towards the patient's right cavernous sinus, and then begin working on the tumor in that area.
Okay.
Again, using Doppler to assist me.
Okay, great. I think that's all I have, and I'm going to hand it over to Dr. Vates here for what
David,
actually
that's a
happened
great
with the
job. You did an excellent work. Ed, all you.
So, yeah, I don't have a specific talk other than, to just kind of go through this particular case and kind of what my thinking was. This is a large intracellular and extracellular growth hormone producing adenoma. And clearly what you want to do, if possible, is to achieve gross total resection / chemical remission. You want to do whatever is required to get the patient's growth hormone back down to normal, and surgery is the fastest, best way of accomplishing that. Although you then have to temper your enthusiasm with an understanding that, as David emphasized, a lot of times these patients have what we call a family reunion disease, meaning that they're diagnosed at family reunions because someone comes up to them and says, "Hey, I haven't seen you in 10 years. Are you okay? You look very different." And that's simply a way of saying that these are tumors that are very insidious. The physical manifestations are very insidious. Patients frequently don't notice anything going on. And it's either an astute clinician or a family member who hasn't seen somebody for a while that recognizes that something has clearly changed in the patient. And so that means that these are typically macroadenomas when they come to medical attention. And the cure rates with macroadenomas, if you look at the publications from Endocrine Society as far as the guidelines for management of acromegaly and look at other series, honestly, the cure rates with a macroadenoma are about 50%. I think other surgical series can talk up as high as 70 to 80%. And when I'm talking to patients, I tell them that in general, for a large tumor, I would say the cure rate with surgery is anywhere between 50 and 70% in my hands. But even though that may not be what you were looking for, it's still a really fast way to get things under control when it works. Now, one interesting thing is that if you have initial surgery and you still have not gotten the growth hormone down to normal, you can still contemplate doing in a second surgery if you know that there's a location where there might be likely to be residual tumor. And this ends up then achieving another 50% in remission. And this is why I had the picture of Zeno over on the right. For those of you familiar with Zeno's paradox, it's the idea that to get from point A to point B, you have to go half the distance and then half the distance again. And you keep having the distance, but you actually never get there because you just keep having the distance that's in front of you. And that's not unlike what we see with tumors like this. And then I think for the next slide, thinking about some of the ways that you go about counseling patients. In the grand scheme of things, again, surgery is the first recommendation. Reoperation may be indicated if you think that there is additional treatment or additional tumor that can be pursued. But there are medical options. There are radiation treatment options. The medical options have actually gotten better because we have more of them, and the delivery and the frequency with which patients need to be treated is changing. It's still expensive. Medical treatments are still expensive, and that can pose a real problem for underinsured or uninsured patients. But I think that as much as I want to try and get all of the tumor out, I know that there are going to be instances where I'm operating in the cavernous sinus, and I may not feel that it's in the patient's best interest to continue pursuing tumor for fear of causing a carotid injury. Or for fear of causing cranial neuropathy. And in that setting, I have to make sure I balance my desire to go for the gusto against making sure that the patient leaves the operating room and leaves the hospital whole, because we do have other options for treatment. Next slide. So one option, one issue that I'm curious to hear about from our honored guest is the techniques for cavernous sinus exploration in his hands, because I do think that it makes sense to do it if it can be done safely. And then also the issue of extracapsular approach, is it mandatory in the setting of suprasellar extension? So this kind of gets at when I'm operating on these tumors, I always leave the option of going extracapsular open, but typically my first approach is intracapsular and debulking of the tumor. And sometimes you get real lucky. Sometimes the tumor is very, very soft and it basically just farts out in front of you. And when that happens, then you can really just use ring curettes and gentle suction. And the nice thing with something like fluorescein is you can then know when you are on the dark side of the moon and you've gotten through all the tumor, and then you just proceed with your resection that way. But there are going to be situations, and in fact it was the case for this lady, where you are debulking the tumor, parts of it are very soft, and then you start encountering more firm or fibrous elements of the tumor. And in that setting, you then have to be prepared to go extracapsular and take advantage of whatever tumor you've been able to evacuate internally to then create space that allows you to mobilize the tumor from the extracapsular approach. And now I'd also be curious to hear what other people's thoughts are about medical treatment before surgery. I have not typically pursued it in my cases when I've done them. Next slide. So, you know, I think it just is, a lot of this is stuff that David already mentioned. Endoscopic is the way to go. In our institution, it's 2 surgeons and 4 hands. Obviously, we use frameless navigation. In this particular case, and it's interesting. When I first started, I put lumbar drains in practically anything with suprasellar extension. As time has gone on, I've actually used it less and less. Thinking back, in this particular case, I did not end up using a lumbar drain. That might not have been the best choice, but I got away with it. Fat graft, definitely, because it's a big enough tumor, you don't want to have the chiasm prolapse into the empty sella when you're done. And in every pituitary case that we do, my ENT colleague has his sights on a nasoseptal flap should we need it, but it's not something that we routinely get during entry unless it's a clear case, or if it's a non-pituitary lesion like meningioma or chordoma or something like that, where I know that we're going to need a nasoseptal flap for a gasket seal closure. And then next slide. So this is, we always get an MRI scan at 3 months follow-up. And it's worth pointing out that, and we'll talk about this later, her growth hormone came down, her IGF-1 levels came down, but it wasn't a complete control. And I think that you can see where there is some residual disease in the left, or in the right cavernous sinus, immediately superior to the inferior portion of the carotid loop. Exactly. And then the pituitary stalk and the normal pituitary gland is still deviated off to patient's left side. The sella looks empty, but that's a mid-sagittal view on the right. If you go to the most recent MRI scan, which is the next slide, here I actually did try and capture that view of the carotid within the cavernous sinus that Dr. Fernandez-Miranda was asking about. And that's to show where the location of the residual tumor was in my mind. So, we took a swing and I'm sorry, go ahead.
Yes, here, I think this is an important point, and I'm going to touch base later, but you look at the sagittal, there is tumor also behind the posterior genu.
Yep.
And that's another very tricky area that the NOS classification doesn't account for. And
yeah.
Touch base. I just want to point that out. Sorry to interrupt.
No. I'm curious to hear your thoughts on that, because that's it. When I have residual, I was actually a little bit surprised about the residual over the carotid, but I'm not at all surprised sometimes to see residual behind the carotid loop there. That is an area that I have difficulty accessing. So I'm curious to hear your thoughts on that.
So Ed, I have a question in regard to your setup, because I know you're very close to your endocrinologist. I don't know what your relationship with your radiation oncologists are. So at this point, were the endocrinologists kind of licking their chops on using medical treatments, or were you or your radiation oncologist saying, wow, that's a target that's a mile away from the chiasm, let's blast the S out of this.
So, for all the patients seen in our pituitary program, they're seeing me and the endocrinologist simultaneously.
Right.
So we're literally co-localized in space and time,
Right.
with the patient in the same room. And our radiation oncologists are very accessible. And we do have a subset of patients that we send there. I mean, the issue is even with stereotactic radiosurgery, in spite of the fact that the pituitary gland is pushed all the way over to the left, if you actually look at the arcs and everything else, at least with the system that we have, which is it's not gamma knife, it's linear accelerator based. You're still going to see a degree of pituitary dysfunction after radiation treatment. And the reality is that this lady had completely normal pituitary function afterwards. And so there are times when we leap right to radiation treatment. If it's a patient where the cost of medication will be prohibitive, or where we think their compliance is going to be difficult, not because they don't want to pursue treatment, but because, for instance, we have a few patients who are migrant farm workers here in upstate New York, and their ability to be coming in for monthly injections is limited, and they travel because they're following the crops. So, in that setting, we will talk with the patient and say, look, we would typically treat with medication, but that's potentially going to be challenging for you. Would it make more sense to consider radiation treatment? But these are discussions that we're having, in real time between me and the endocrinologist, and pretty easily with the radiation oncologist. And so we kind of balance all those things and tailor to the specific patient. For this lady, she wanted to try medication next. We talked about the option of repeat surgery to see if we could get access to that portion that was in the cavern of sinus. But she sailed through surgery, but still it was surgery. And, she didn't want to have to go through that again if she thought that medication could work.
And so what was the final outcome on this? She was treated with medication?
Yes. So she's been treated with somatoline, and she did go to radiation oncology ultimately. And they actually chose to treat this with IMRT, so intensity modulated radiotherapy, not a radiosurgery. But her growth hormone levels are, sorry, I misspelled that, it's IGF. And in spite of the radiation treatment, she, at least at this point now, 3 years out, I think, from radiation treatment, she has not gone on to have any evidence of hypopituitarism.
Okay.
I will make another interesting point, which is, you probably guys are familiar with the literature showing that radiosurgery response, I'm not sure for IMRT, but for radiosurgery, is better if patients are not in medication before radiation treatment, which is something interesting to consider on the strategy.
Yeah, I mean, the issue was our endocrinologist wanted to get her growth hormone levels down on the sooner side. I actually believe that they may have paused her medical treatment during the time that she was getting IMRT, and then resumed it again afterwards. And then, of course, after you've had radiation treatment, at some point you start to taper back down off the medications again because you may not need it anymore. And I think that's in the domain where she's at right now. I think they're starting to bring some of her medication down.
Mike?
Question, how quickly do you expect the IGF-1 level to normalize after a successful surgery? So usually it trails the growth hormone levels a bit.
Yeah, I mean, we follow IGF-1. I mean, really, we tell patients we're not going to pay much attention to IGF until at least 3 months after the surgery. And sometimes if it's moving in the right direction, but it's still, if it's getting close, if it's like perinormal, not paranormal, but, close to normal, we may choose to follow it every 6 to 8 weeks after that. And then at 6 months, start treatment. But I know that, the endocrinologists are anxious to get things under control. And that may mean that we don't necessarily start with somatoline, but they may recommend starting something like cabergoline. I mean, cabergoline is now being used for growth hormone producing tumors. We actually use it on our Cushing's patients. In fact, I have a patient recently that we operated on for Cushing's who doesn't have any gross tumor on her MRI scan, but clearly was still hypercortisolemic after surgery. And they started her on just a half tab twice a week of cabergoline, and her cortisols have completely normalized. So usually cabergoline is what we do while we're still coming up with what we want to do.
All right, thank you,
Well, let's
everybody.
switch
That was fair. Yeah, go ahead, Mike. Let's switch screens now to Juan's. So Juan, you have the podium, and please give us your perspective on this case as well as this topic in general.
Well, thanks of all. Thanks, Walter. I really enjoy your webinars. I think you're a terrific host. So amazing job. Second, Ed, nice job. I mean, that's a tough tumor and you got a very nice result. I mean, there is some residue in the cavern of sinus, but it's minimal and it's a very nice resection. So I'm gonna show with you some of my recent experience and data on acromegaly. And I wanna acknowledge my team, and in particular, two individuals here, other than my ENT group, my endocrinologist, and Dr. Kat Nelson, who is a true expert on acromegaly, and my clinical instructor, clinical fellow who has put a lot of this data for us. So I'm gonna make 3 points in this talk. One is that, as I'm gonna show you, adenomas invade growth hormone adenomas. This means invade the middle wall of the cavern of sinus much more often than previously reported. And in fact, you're gonna see how the invasion rates depends very much on the cell lineage. Depending on the type of tumor, the invasion rates change very much. Also, I'm gonna show you how removal of the middle wall may improve in a very significant way outcomes in terms of remission for functional tumors and gross total resection rates. And 3, when you're experienced, you can do this safe with no complications, with very low complications. So first, of course, we need to all focus on understanding the cavern of sinus anatomy from transcranial perspective, from endonasal perspective. And some of you might be familiar with this work we put together on the compartments of the cavern of sinus. We describe compartments that are above the carotid, that are behind the carotid. This is the one I was mentioning on that post of MRI, because this compartment is neglected and is very relevant. And then inferior compartment. And it's funny because when I was working on this paper, it's at the same time that the modified NOS paper came out, and I said, damn, this was just screwed. But the truth is, both classifications are different and they have different purpose. The work we did on anatomy of the compartments is an anatomical classification, and it helps the surgeon to guide the anatomy, to guide the operation, to predict what anatomical structure you're going to find, to help to do better operation on each compartment. NOS classification is based on radiological studies. It's not a surgical classification. It helps us predict the possibility of invasion of the cavern of sinus, but it doesn't help us that much in terms of surgical strategy, in my opinion. So when we talk about superior compartment, there are different structures we need to remember. Is where the third nerve is located in the oculomotor triangle, but the third nerve is protected by a layer of dura. So it's, in my opinion, very safe to work up here to remove tumor, because in terms of the third nerve, you need to recognize a very important landmark, the interclinoidal ligament, which separates clinoidal triangle, where the carotid is, from oculomotor triangle, where the third nerve is located. Then we have this tricky posterior compartment. It's behind the gene of the carotid. And it's tricky because you need to actually mobilize the carotid some, so you need to work behind the carotid. And the sixth nerve is at the bottom of this compartment. So you have a risk of sixth nerve injury. As opposed to the third nerve that I think is well protected, the sixth nerve is not protected. So you can get a sixth nerve palsy post-op working here. I use a very important landmark to find the sixth nerve, which is what is called the petrous apex. Actually, it's not the petrous apex. We're publishing on this. Is the petrosal process of the sphenoid bone that joins the petrous apex. You find that bone, and the sixth nerve is just on top. So it's a great landmark. But to see that, you need to fully skeletonize the carotid and expose it. And I'll show you that in a video. And then we have the inferior compartment. This is the one that goes below the horizontal cavernous carotid. And also here, the sixth nerve is at risk, but it is at lower risk because the sixth nerve is just lateral to the carotid. So we can work quite safely here. We need to be careful as we approach the lateral compartment of the cavernous sinus. Now, in addition to compartments, I realized that actually understanding the walls of the cavernous sinus has become extraordinarily important. And understanding these walls from all perspectives, transcranial and endonasal. And endonasally, we need to think about the medial and the anterior wall of the cavernous sinus. As you all know, we have 2 layers of dura on top of the pituitary, but as these 2 layers come, they go lateral, they separate one from the other, and they form this cavity. There is single layer. So the anterior wall of the cavernous sinus is that periosteal dura. The medial wall of the cavernous sinus is that meningeal dura that surrounds the pituitary gland. So this is a very simple concept, but it's extremely important. Of course, we have precedent of other surgeons working in the cavernous sinus medial wall. And we have Ed Oldfield with an amazing experience with Cushing's disease, where he described a technique to incise this medial wall and remove tumors from there. And we have a Japanese group with a lot of experience describing aggressive surgery in the cavernous sinus, including resection of the medial wall, with remission rates as good as 85%. So some years ago, we started studying this in the laboratory and comparing with our surgical experience, and we found that the medial wall has a very interesting structure. It has a number of ligaments, which we call paracellular ligaments, that go from the medial wall to the carotid and to the other walls of the cavernous sinus. And we studied this in detail. The most important ligament of all of them is the carotidoclinoidal ligament, because it's nearly always there. It's a very robust ligament that goes from it kind of anchors the middle wall of the cavernous sinus to the carotid, and it actually forms the roof of the cavernous sinus, is what defines the separation between clinoidal space and clinoidal carotid and the cavernous sinus itself. And this ligament continues behind the carotid to join the anterior clinoid. If you look behind this ligament, you have the interclinoidal ligament, which is actually embedded in the dura. But this ligament comes from the medial wall. It is a key ligament because as you try to remove this medial wall, you have to transect this ligament. And I've seen more and more cases of this ligament actually being invaded, the tumor tracking along this dura in the proximal dura ring. There is another very relevant ligament, which is the inferior paracellular, and it's relevant because it's almost always present, and it's the first one we find when we open the anterior wall of the cavernous sinus from inferior to superior. So it's usually not a very robust ligament. It's not like the other one. It's easier to transect, but it's good to identify it, and also is key because behind this ligament, we have the inferior hypophyseal artery. Always my main concern, or one of my major worries when I work inside the cavernous sinus, is injuring not the inferior hypophyseal artery itself, because it's a small artery you can coagulate, but avulsing this artery from the wall of the carotid and creating a hole in the carotid artery, and that can be problematic. So I always like to find the artery, and usually I coagulate and transect the artery as proximal as I can to the carotid so I don't avulse it from the wall of the carotid artery. There are other ligaments, difficult to classify, less frequent, but you can find other connections there. So for those interested, we published this a couple of years ago, very detailed study. And we had a second part on this study, which is, it was our experience while I was in Pittsburgh of our first 50 patients doing this technique. Based on this anatomy, we described this resection of the middle wall of the cavernous sinus in different steps. So in those 50 patients, we had no injuries to the carotid artery. We had 8%, 4 patients developed transient 6-nerve pulses that resolved completely at 3 months. And this is definitely manipulation. Some of the packing you place, the 6th nerve is very sensitive, but at the same time, if you don't injure it, most of the time it gets back to normal. And in this study, 86%, we meticulously send the wall to the pathologist, and we analyze whether there is invasion or not. 86% was positive histologically. And the remission rates, maybe they are not that relevant because the follow-up was very short, but the results were good. So now I've continued with this work as I started here at Stanford over my last 2 years. And we just reviewed the consecutive 100 primary pituitary tumors, primary meaning non-recurrence tumors, 100 cases. Of these 100 cases, I actually removed the middle wall in 51 of those. But if you look at the numbers, I removed the middle wall in 21 out of 24 somatotroph adenomas, 87%. But for example, only in 38% of gonadotroph non-functional adenomas, which I know is controversial, but as you will see, we tailor When do I remove the middle wall? When I think it's invaded. It's all based on my intraoperative inspection. If I think it's invaded, I think there is tumor there, I remove it. These are the results that you see. And interestingly, we can look at how often the medial wall that we remove is positive in histology. For example, I was saying it's controversial removing the medial wall in non-functional adenomas, and moving in 10 cases, and all of them had positive histology. So I'm selecting those patients very well, I believe, because all of them are positive. However, you see on somatograph adenomas is 70% or a bit more of 70%. And the same with others as you see. So I don't know if the 25 to 30% negative histology, is it true that is negative, or is actually a sample or a technical error? Because some of these medial walls, they have some crash artifact, sometimes you coagulate, there could be a, sampling error might play a role. But of course, some of them could be negative. But again, I remove the wall when I think it's invaded. Something also very interesting is looking at the correlation between NOSP and invasion of the medial wall. And this is just for acromegaly cases. I was extremely surprised myself when I saw this. Grade 2, 3, and 4 always have invasion of the cavernous sinus. Grade 3 and 4 perhaps is a no-brainer, but grade 2, there are in my series, which is not a lot of cases. For example, these are only 5 cases on the grade 2, but all of them had invasion of the cavernous sinus. But when you see grade 1 and grade 0, we had 7 cases with, 29%, let's say, of cases grade 0 with invasion of the wall, and 57 in grade 1. So even in small adenomas that are just touching the wall, there could be invasion. So I'm always in the look for this. And this actually explained to me why in my earlier experience, when I was starting doing these cases years ago, a decade ago, I had some small tumors with no remission. I was saying why I would not get a remission in a small adenoma if I'm removing all completely. I think the answer is because there is certain degree of invasion of the wall of the cavernous sinus. So I'm going to show you this example. This is a grade 0, I would say, NOSP. You can say grade 1 if you want to argue, but definitely no more than a 1. So this looks like a very simple tumor. So we do our exposure, but when I see that the tumor is touching the medial wall of the cavernous sinus, in that case, I'm prepared to explore the cavernous sinus wall. I need to be able to see it. So I'm doing a good exposure. As you see, I remove the bone that covers the carotid and the anterior wall of the cavernous sinus. I like your, Ed, as you mentioned, the extracapsular dissection technique. We try to apply it, but I don't think it's that relevant. I try to do it, but often these tumors are soft. I think what is important is to separate tumor from gland, right? Differentiate that playing well. But look at this. You saw those 2 implants on the middle wall of the cavernous sinus, and those were there. I could not aspirate those. So what I do is then I decide to open the anterior wall of the cavernous sinus. Of course, you have venous bleeding, but we have the hemostatic agents, which are very effective to stop this. And then I carefully start peeling this medial wall. Here you need to separate medial wall from floor, which is outer anterior wall. Floor and anterior wall come together. So once we separate one from the other, we start seeing the inside. So one is the medial wall, the one is the anterior wall. And then I'm coagulating and transecting the inferior hypophyseal artery and the inferior paracellal ligament. My next landmark is that posterior clinoid. I dissect the dura along the posterior clinoid. That detaches the medial wall up to the posterior wall of the cella. And you can see that nugget of tumor right there growing through the wall of the cavernous sinus. Small, but an implant in that wall of the cavernous sinus. And then I'm detaching the wall superiorly, and I'm resecting this wall practically en bloc. And then I can send it to the pathologist, and they can analyze it. The other option is you can just coagulate those residuals, but this is, I would say, definitely more effective to completely remove the tumor. And then we send, this is the wall, we send it to the pathologist, and they confirm that there is tumor. So this came as a surprise that, these small adenomas can actually invade the middle wall of the cavernous sinus, but I would encourage all pituitary surgeons to take this seriously and explore the medial wall and see if they see any evidence of invasion. And if that, try to learn the technique, because I think it can improve outcomes for your patients. And this is at the end of the resection. So this is another case. As you see, this case actually is maybe a NOSP 2 or maybe 3. because this is difficult when the carotid is so tortuous right there. I'm going to show you the sagittal view. As I said, I like always to look at the sagittals. If you look at this sagittal, you can see that invasion right there. And it's tracking very much. It looks almost like that residual tumor in your case there, that is going along the superior compartment. So let's see this case. So we're doing the approach, and as you all know, acromegalics, they have tortuous carotids. They are more difficult to deal with. They are large and tortuous, but still, we try to do the best we can with our approach. And this approach was not easy because all the bone that was covering that carotid. But I know that I need that exposure. Without that exposure, I won't be able to remove this tumor safely or completely. Always using the Doppler is a great adjunct, of course, for surgery, much more important than image guidance, for example. And then we're finishing our exposure. You see the whole anterior wall, the cavern of Sinus and clinodal carotid is exposed. And then we're opening. As we said, the key here is to find your interface between pituitary gland and tumor. Usually you have this thin layer veil of pituitary gland covering the tumor. You find that, you follow it to one side, the pituitary stays on the right side of the patient. And now this is the tumor. You see some of the arachnoid herniating down. And then this is the floor. And the floor is clearly invaded, the dural floor. I'm not yet in the medial wall. But I know that I have here tumor. And this tumor, I can try to aspirate, but I can only aspirate so much. I know there is disease that is going through the wall. So what I do is, again, opening the anterior wall, the cavern of Sinus. You saw that little tool that is a right angle knife that has a blunt tip and a sharp upper edge. And it's extremely useful for this type of opening because you can put it against the carotid without being sharp. And this case was very difficult because this very tortuous carotid, there is almost no venous pocket compartment between the carotid and the dura. But, we start dissecting this dura of the carotid. And, this is not an easy technique. It definitely is not. And I believe it has to be done when you have developed significant experience because you are literally peeling this middle wall of the carotid artery. And it can be, nerve-wracking. So you need to be very comfortable doing this. So we finally found all the way to the posterior clinoid. Always the posterior clinoid is your landmark posteriorly. And then the middle wall feels very heavy. It has tumor inside. So I'm opening and debulking a little bit of that. But I know there is tumor on the other side. So I keep dissecting and opening the wall as I go, progress superiorly towards the carotidoclinodal ligament, which is my upper limit. And this has multiple steps. You have to put flow seal, stop, or hemostatic agents, and irrigate, and again, and again, and again. And this is, you see the tumor that is growing through the wall, and actually you see there's some ligament attachments there. So the tumor is embedded in the wall, and that wall has ligament attachments to the carotid. You cannot suck the tumor out. You have to find those ligaments, coagulate them, cut them, and remove the wall that way. And in purpose, I put this video so you can see the amount of venous bleeding that you need to deal with. What I'm doing now is I went above the carotidoclinodal ligament into the clinodal space. So I could actually transect the carotidoclinodal ligament and start bringing the tumor. Look at that yellow thing. That yellow is tumor inside the ligament or inside the wall as it becomes the ligament. And as I detach it, I can now gently pull that tumor out because I cut all those ligaments and the inferior hypophyseal artery. And I stop again, and that posteriorly actually is, I believe, the inferior hypophyseal artery, which we're going to identify right there and coagulate and transect. You see how thick is that wall because it is full of tumor. So this tumor is actually not completely freely invading the cavern of Sinus. As you know, some tumors invade the cavern of Sinus, destroy completely the wall. There is no wall to be identified. It's not the case. It's not the case here, and in many other cases, you see how this tumor is embedded without that wall. So you have to anatomically disconnect this middle wall, posteriorly, and then superiorly on the carotidoclinodal ligament, and then, of course, we did anteriorly the first and inferiorly along the floor. And at the end, that tumor, you see how it's nicely contained within the wall. Another ligament posteriorly that I'm disconnecting. And that brings the whole tumor out from the superior and even from the posterior compartment behind the carotid artery. And now I'm just looking for any residual. That's, you see there, the posterior clinoid, and I'm looking at, that is just the dura, where the posterior cellar dura becomes the middle wall. So I'm just making sure that there is no residual there. And just below there is where the Dorellos canal is located and the sixth nerve entry. So you explore to make sure there is no residual tumor. Again, more proximal inferior hypophyseal artery, which I coagulate. And I transect this posterior wall also to make sure there is no residual in there. And you see the posterior clinoid, and that's a beautiful view of the interclinoidal ligament. When I see that, I know that the whole medial wall has been removed, because that interclinoidal ligament is between the roof and the posterior wall. All medial wall has been removed. So I know that looks like an aggressive operation, but I do think that if you do it following anatomy, you're doing with good technique, your outcomes can really get better. This is just a summary of some of our cases in our series here at Stanford. You see we have a number of large tumors. Some of them, for example, this first tumor did not, I couldn't get a complete resection. There was still some residual stuck to the carotid, and this patient got radiation. As in your case, Ed, this patient had a pre-op growth hormone level of 65. Any growth hormone level above 44, the prognosis is not good. And the chances for curing it with surgery, we know, is not good. But these others have 40, 40, all these patients are in complete remission. And then you see other cases, all with complete remission, except that first one that is a NOS4. We studied this and we put all these cases together on, sorry, this didn't come up, but these are IGF-1 levels before and after surgery or at last follow-up. And you see the nice decline of the IGF-1 levels. Not all patients are in remission, but we have a remission rate of 85%. We have 4 patients that are not in remission. Of those, we did 1 radiosurgery. Another patient is going to go for radiosurgery surely soon. And there are 2 of those with medication, and 2 we are watching because they have no symptoms. They have an IGF-1 level that is mildly elevated. So it might come down later. We don't know yet, but they have no symptoms. The endocrinologist prefers to wait. So these results are better than reported, and also better than my own results. These are my results when I was in Pittsburgh, our results. Our remission rate was about 50%, improved to 85%, 70% with adjuvant therapy. All my patients in 100% are right now in remission with adjuvant therapy. Of course, as you get more complex cases, if I get more NOS4 cases, truly invasive, encasing the carotid, then the results will start getting worse. But fortunately, those are not the most common cases. Just a last word on radiosurgery. I think there is definitely a role for it. But as I said, only one patient in my series had radiosurgery. There will be a second one. Radiosurgery as an adjuvant treatment, it has some risks. The risk of new endocrinopathy is about 26%. The risk of new cranial neuropathy that is permanent is about 4%. And this is not transient. So this is, something to consider. The risk of injuring the cranial nerve with radiosurgery is higher, in my experience, than with surgery, because those cases are transient. So the medial wall of the cavern of sinus resection technique is not an easy technique, but it's a very useful technique. To me, it's all about understanding the carotid artery in the cavern of sinus, understanding the different loops, the different segments, the ligaments that attach to it, the branches, and just be able to just dissect the carotid all the way, and at the end, you get a nice view of the whole carotid dissected, and that is the goal. In terms of complications, these are included also recurrent cases, 108 consecutive cases done at Stanford, 58 medial wall resections, no IC injury, 2 patients with transient diplopia, both improved, no permanent morbidity. So these results, of course, are after 10 years of experience in Pittsburgh, then coming to Stanford. So they're not applicable to everybody, only to those that develop that experience through learning curve and laboratory training, and of course, significant clinical experience. So just to conclude, I hope that I've showed you that, more than half of pituitary adenomas actually may invade the wall of the cavern of sinus, and the rate of invasion is highly dependent on the type of tumor you're dealing with. Acromegaly patients, they have invasion of the middle wall more often than other tumor types. And if you remove the middle wall because of that invasion, you can improve your remission rates in a significant way with low complication rates. I just want to end. Thanks, Walt, for the kind words, inviting you guys to attend the second weekend of the Rotom Society meeting. This has been a great event. We've hosted here at Stanford, but has expanded globally. More than 11, we had 111 countries represented, near 2,000 people registered, something that I think Professor Rotom will be very proud of. So thanks so much.
Well, thank you for that fantastic presentation, Juan. Really a tour de force. Before I get into questions, I have my own question to ask you technically. So it seems to be the critical steps are you expose that ipsilateral carotid. You really take all the care of getting all the bone off.
Yes.
That's step number one. Number two, you open the anterior wall, and then you find the medial wall and you start dissecting from a lateral to a medial direction. Is that correct?
Yes, that is correct. So as you said, first, very good exposure of the carotid, that's key. And then you want to find that point of cleavage between as the floor becomes medial wall, becomes anterior wall, and then the medial wall. And usually there is, because of the loop of the carotid, you usually have a pocket of a venous pocket that you can enter. And that's when I use a dissector and the knife to open that widely. And yes, I like to open the cavern of sinus widely. You get a lot of venous bleeding, but then you pack it. I also use, reverse Trendelenburg to decrease venous pressure. That also helps. And then I directly face the cavern of sinus from the front, or as you said, from lateral to medial. I need to see the carotid. I cannot remove the medial wall without directly seeing the carotid. And I'm not going to start cutting things until I identify the carotid. And I need to understand what is the horizontal carotid, what is the posterior genu, what is the, all that anatomy, I need to have it clear.
I mean, in my mind, thinking about it now, it's not unlike, when you split the fissure, you try to get deep into the fissure and identify an artery and then work along the artery, because the arteries are the most substantial thing within the fissure. And so in many respects, the carotid is the most substantial thing in the cavernous sinus, the most awe-inspiring and most feared for part of the cavernous sinus, but it is also the most structurally robust thing in the cavernous sinus. And so in a way, getting onto that wall, external wall of the carotid, and using that as your pathway to then tease tissue out of the cavernous sinus medial wall off, and creating it, I mean, that makes perfect sense.
Absolutely.
Just all the damn bleeding that.
Exactly. It is, as you very well said, I think you fear what you don't see. If I don't see the carotid, if I'm not seeing the carotid, I'm taking a tumor, I don't see the carotid, I'm in fear. I don't know when the carotid is going to be. But if I see the carotid, I feel that I have things under relative control.
How does a tumor consistency affect your dissection? I mean, when it's a soft tumor that you can suck in, really get a good visualization of the medial wall versus these fibrous, tough tumors that that are stuck. How does that affect your dissection and resection of the medial wall?
Well, it makes it more difficult, no question about it. It makes it more difficult. And it is usually the case that the medial wall, the tumor in the medial wall is fibrous. By definition, is embedded in fibrous tissue. So that portion is always going to be fibrous. So this is more difficult, in my opinion, much more for me, than when you have a soft tumor that widely invades the cavern of sinus, the wall is destroyed, and you just need to go carefully with your suction removing tumor. That is not very difficult. This is much more difficult. You have to, not only is fibrous, but it has this attachment and this connection. You need to carefully disconnect one after the other so you can remove it completely.
As the producer of this, TV program, if you will, I feel like I have to say, don't do this at home, boys and girls.
Yes.
But that's just being funny and facetious, but I think this is a monumental contribution to neurosurgery, Juan, and I congratulate you on this. But it's something that you don't just do by doing. This is something that you learn first in the lab and maybe watching experts do it in live surgery and then being trained to do this. So yes, it's something that's important to know, but don't go and try this at
Well, and I think like if you are just finishing training and you're going out and you're about to do your first endoscopic pituitary, trying to dissect the medial wall of the cavernous sinus is probably not the first place to go. That being said, after you've done 40, 50, 60 endoscopic surgeries and you develop that psychomotor skill set, I mean, in many ways, pituitary adenomas are the L5-S1 disc of endoscopic skull-base surgery. And so you do enough of them and you learn that psychomotor skill set, and you can then start tackling more nuanced, more technically challenging aspects of it, like this, or like, chordomas, or meningiomas, or any of the other things that we tackle through the endoscopic approach.
Absolutely.
At some point, you just got to start doing it, right? I mean,
Right.
it's fine to say, yes, you need to be in the lab, and obviously, it helps to do all of that, but eventually, you either piss or get off the pot.
Well, and since we're talking frankly, every carotid injury that you get sets you back a couple 50, 60 quanta of doing this. Having experienced that too many times, that kind of puts you a little bit more conservative, learning from that complication, and which is also a time to maybe bring up the fact that radiosurgery, when done properly, can be a very good adjunct and can maybe avoid some complications sometimes. Having said this, I'm total buy-in on this technique, and I wish I could learn that quickly myself. I think we're quite out of time.
That's why I put this graphic here on the Dunning-Kruger effect, because you can climb very high, very confident if you see my talk, and then you get an injury and you are going to drop, dramatically. So you need to follow the curve, and it takes time, it takes patience, it takes training. Absolutely.
With that, we are over time now, and I want to let our panelists go and rest up for the next day. I want to thank Juan, Ed, David for their efforts in this panel, and of course my course director, Michael Huang, for moderating. Juan has already talked to you about the Roten Society meeting this weekend. I plan to jump in as much as I can to listen and learn some more. But also, please remember, Surgeon's Log 2020 comes back to you in 2 weeks with yet another exciting episode. We are traveling away from the anterior space this time. We're going straight lateral back to the otology space. And the otologists are all saying, thank God, finally. But we're going there next time. So stay tuned.